Okay, everybody. Welcome, welcome, welcome. Welcome to those who are in the room, and also welcome to those that are online from home or work or wherever else it is. I'm Professor Andy Ustinowski. I'm a clinician, an infectious disease clinician, but I have a few roles. The most relevant here is that I'm the co-clinical director for Greater Manchester Clinical Research Network, based just up there. But I'm also the chair of the SDE Programme Board for Greater Manchester, and I'm going to be chairing the next couple of hours, where really what we're going to be doing is exploring a pivotal initiative and a pivotal asset for the future of health and care data and research in Greater Manchester, which is the secure data environment. In terms of housekeeping, I understand we're not expecting any fire alarms, but if there are fire alarms, for those of you who are here, the directions to go are listed on the doors, the two doors there. If you need the toilets, back out around the sofa, and there are some toilets around the corner there. And for those that are tuning in, I have no idea about your fire or your toilet, but I hope you do. Okay, this is going to be the agenda of today. In a second, Gareth is going to talk about the digital strategy for Greater Manchester, followed by Bradley giving an introduction, a little bit more detail about the secure data environment. I'm just going to touch on the programme board and introduce some of the lighthouse studies, or introduce the concept of lighthouse studies. And then we have a series of presentations about the lighthouse studies, the pressure testing projects that we're going to put the SDE as it's being developed through, which is going to be John Radford and Rachel Oakley from the Christies. We've got representations from the pharmacogenetic team. I think Bill is due to come, etc. Oliver talking about ID liver. Ian talking about SLE, and then really importantly, we have a panel discussion at the end. So as this is going on, please, audience here, but also audience at home or at work or wherever you're tuning in from, please start thinking about any burning questions that you've got. There's a few things that I want to touch on, but this is a session for you lot. So start thinking as we're going along what questions you'd like answered. We're not planning on asking questions or answering questions after each of the different studies. If there's some burning question about the study which is specific for the Lighthouse study case, perhaps catch the person right at the end. If it's more generic, then by all means put it into the panel discussion at the end. So I hope that works for you all. It is your session. If you want to take it off in a tangent, feel free. We are slightly tight for time, so those people talking, I might be waving at you frantically to say speed up or you know, finish off, just so we get enough time for that panel discussion at the end. Great. Well, let me invite up Gareth Thomas, who's going to be talking a little bit about the digital strategy and the role of the SDE. Thank you very much, Gareth.
So good morning, everybody, and a really warm welcome to everybody here and everyone who's joining us online. I'm Gareth Thomas. I'm the Digital Innovation Director at Health Innovation Manchester. I've been in post since around February this year. By background, I'm also a clinician. I'm an intensive care consultant in Salford Royal, where I continue to practice. And it's an absolute privilege to be here today at the launch of the SDE, which is a huge milestone for all of us in GM, and particularly for the 2.8 million citizens we serve. So what I'm going to do today is just do a bit of context setting, really, tell you what the SDE means in terms of our digital transformation strategy, and just give you an indication of a few of the sort of the key anchor points, if you like, within our strategy. So first, a little bit about Health Innovation Manchester and the role of Health Innovation Manchester. So the vision for Health Innovation Manchester, as it says on the slide, is to become a recognised international leader in accelerating innovation to transform health and care. We do this via a specific methodology, and the SDE is key to this methodology and this ambition. So we're looking to discover, develop and deploy innovations at scale and pace across Greater Manchester. We're looking to build really firm industry and academic partnerships such that we can get a new model and a new relationship to accelerate speed to market and demonstrate proof of value. Of course, within GM, we've got one of the largest life science clusters within the country. So there really is a huge opportunity here. We're looking to provide access to market, provide signalling, and build a robust research, development and innovation ecosystem to really increase productivity within the region and help the 2.8 million citizens that we serve. So the SDE really is integral to this ambition for Health Innovation Manchester and for Greater Manchester. We're also working really closely with the Integrated Care Partnership. This is the ambition for GM ICP. And you see in the last few words, they're growing old in a green, fair and more prosperous city region. And the SDE, again, is integral to this ambition, particularly supporting 4 of the 6 key missions. These are around prevention and early detection, recovery of NHS health and care services, financial sustainability, and increasing prosperity across the region. So the SDE is really closely aligned with the ambition of the Greater Manchester Health and Care Partnership. Within GM, we have the real opportunity to become a world-leading digital city. One of the things we've got within GM is a really good, clear understanding of the current digital status within health and care and what we need to do to improve and build innovation on top of this digital capability. So over the last 2 years, we've had a really novel digital maturity assessment across Greater Manchester, which has collected over 1,700 data points around the digital maturity in health and care systems. We've consulted with over 500 citizens, and this strategy is now being socialised with staff, with citizens, and with the senior leadership across Greater Manchester. And what I describe to you now is how the SDE, again, is an integral part of this strategy. So the strategy for digital transformation across Greater Manchester has 5 ambitions, as you can see outlined on the slide there. Deliver integrated and safe care, operate productively and efficiently, empower citizens to manage their health and care. And then the final 2 ambitions around understanding population health and accelerating research and innovation into practice. So whilst the SDE talks to all of those ambitions, it's particularly pertinent with those final 2 ambitions of population health and accelerating research and innovation into practice. So where did these ambitions come from? So I'll just outline really briefly the final 2 ambitions around population health needs and research and innovation into practice. So these came from a really deep consultation exercise, as I've described, both from the point of view of citizens and staff. So from a population health perspective, citizens have told us that they want to be, if they're at risk of a particular condition, they want to be aware of this and proactively notified. They want to feel that the care and treatment they get is fair and equal, and that technology speaks to them and includes them. Staff have told us that they want to deliver responsive, personalised, timely services and identify patients who have the need for intervention and intervene early. So the SDE really supports this ambition to support our population health management, identify patients at risk, intervene early, and offer new interventions where possible. The SDE also supports our 5th ambition for Greater Manchester, which is around the acceleration of research and innovation into practice. So citizens have told us that they want to know that they're benefiting from leading edge, cutting edge treatments for their conditions. They also want to know that where their information is used, it's used securely, and that there are protections around the utilisation of that data. Staff have told us that they want to be able to offer leading edge treatments to their patients and work together with academia and industry. So again, this is where the SDE is fundamental to that 5th ambition within our transformation strategy for digital within Greater Manchester. Just a little bit on how are we going to do this. So I've told you around the 5 ambitions. There are then 3 layers of activity which will support the delivery of those ambitions. The lower layer is digitise, essentially investment in infrastructure and technology to level up across Greater Manchester, the digital capability. Now, clearly, if we're going to collect information from the system and innovate, we have to have that fundamental infrastructure layer in place. The next 2 layers are around integrate and innovate. And this is where the SDE really starts to talk to our strategy. So integration the sharing of information across care settings between professionals and from professional to citizen. The SDE is essential in terms of supporting that ambition. And then the top layer there, as you can see, is innovate, delivering new treatments and care packages to patients and citizens as and when they become available. And again, the SDE will be a fundamental contributor to that ability to innovate in a timely fashion to improve the health and care of our 2.8 million citizens. So we have 5 ambitions, 3 layers of activity, and the SDE is an integral part of those layers of activity. So final couple of points from me. The underpinning of the secure data environment is the GM care record. This is a longitudinal record which cuts across all care settings. Through the information available within this record, this then informs the secure data environment for those lighthouse studies and other innovations. The text is quite small on the slide there, but what this is demonstrating really is how, in the context of the pandemic, there's been a tremendous acceleration in the use of the GM care record. So we now have one integrated system. We have 3.1 million patient records accessible from 100% of practices. We've got one data sharing agreement across the system. We've been able to have some early research studies during the COVID pandemic, but now the ambition is much greater in terms of access and training for the record, in terms of the use of integrated care planning and shared care planning across different systems. And then finally, for the use of the SDE on top of the shared care record. And you'll see that what's popped up in there in green is the fact that about 2 days ago, I can see smiles in the audience, they all know this is relevant. About 2 days ago, we got CAG approval for the use of the secure data mart for secondary uses and research purposes. Just to say a huge thank you for the team. This is, I can't tell you how significant this is. This is fundamental to our use of the SDE. It's also, I think, an England first that we've got this level of approval. This was quite a challenging process, but the fact that we now have this approval switches on that ability to utilise the SDE for a range of research studies. I know Bradley will talk a little bit more about that in detail. But now that we've got that, you can see on the right-hand side of the slide there what it is we can start to do with the SDE in terms of clinical trials, real-world studies, translational research, and health service and operational research. So in summary, we've got a huge opportunity in GM to be a world-leading digital city. We've got great understanding of what it is we need to do to transform our health and care from a digital perspective, both in terms of our 5 ambitions and in terms of those 3 layers of activity to digitise, integrate and innovate across the health and care system. The SDE is a fundamental component within this strategy and really will enable us to build improved healthcare and prosperity for our 2.8 million citizens. So we're going to hand over to Bradley now, because Bradley's going to tell us a little bit more detail around what the SDE is to build on the context that I've outlined today. So thank you, and over to Bradley.
Fantastic. Hi, everybody, and thank you, Gareth. It's so exciting to see so many people here in the room today. In some ways, today's event is very much a culmination of a journey that we've been on over the past few months to get to this point around the secure data environment, an extraordinary amount of work to get us to today, but also in lots of ways, the beginning of an exciting journey that will go on over the next few months. So my name's Bradley Quinn. I'm the Associate Director of Insight at Health Innovation Manchester, and I'm the lead for the Secure Data Environment Programme for Greater Manchester. Over the next 15 minutes or so, I'm going to focus on that journey that we've been on around the secure data environment, why today is such an important, crucial milestone for the secure data environment, and where we go next to deliver that ambition that Gareth has outlined for Greater Manchester. And I wanted to start with a problem that I think we all experience far too often, which is that the health and care data landscape that exists today across the NHS and more broadly is far too fragmented. The NHS and the data opportunity we have with the NHS is unique globally, We have a single NHS number that follows every patient all the way through the life course that we can connect up between primary and secondary care. We have almost full unbiased representation of our population. It's not based on your ability to pay or whether or not you've got insurance. So a real opportunity. But paired with that, across the NHS nationally, we have over 42,000 individual data controllers, be they GPs or hospitals or social care settings, etc. There are over 500 data controllers in Greater Manchester alone as part of that, all with their own individual front doors, all with multiple points of access to this fragmented data. So what that means in practice is that data sets can often be or can feel siloed. They're restricted in primary care or in secondary care or other places, and their usage can be limited by really strict constraints around how they can be used for different purposes. That means in practice that oftentimes we can't see that full patient experience. We can't understand them from a holistic perspective and how they interact with the different services we provide across Greater Manchester. But we all know about previous initiatives that have tried to join up the dots and connect things up that have failed pretty catastrophically, be it care.data or the National Programme for IT, or more recently the GPDPR initiative, which the BMJ called Big Brother's Big Data Grab. And we need to learn from those initiatives. In parallel, the shining light at the bottom of the slide there is over time, we've seen significant development in the kind of digital capabilities we've got in Greater Manchester, which means very much like the $6 million man, we've got the technology now to offer that assurance to patients around the appropriate, secure, trustworthy use of their data. So that's the problem that we face today, but paired with that, there is a significant national ambition to do things differently from what we've done before, and realise that untapped potential that I mentioned around NHS data. So this is the objective of the National Data for R&D programme, who are providing funding to support the development of secure data environments. And it emphasises three elements in particular. The role of data in enhancing patient care for R&D purposes, how R&D sustains the NHS, and that's particularly pertinent in the kind of financial climate we are today, and also how research and development supports innovation, the development of innovation and the adoption of innovation. So a significant national ambition. That big national mandate for investing in R&D has then come through a number of key national policy drivers and landmark publications, and we've reflected a few of those on the slides here. So I'll start on the left-hand side as you see it. The Goldacre Review, better, broader, safer. I have to try and not say that too quickly because I get a bit tongue-tied. So the review by Goldacre and the team made 84 recommendations in total, how to support the safe use of health and care data for research purposes, with a really strong focus on the role of secure data environments in building public trust and ensuring fair and appropriate access to data. There's the Life Sciences Vision, which is all about how do we provide innovators with smoother and quicker access to reliable but real-world data to develop treatments that save lives and which help to develop innovations for the front line. Last week, there was the James O'Shaughnessy review of commercial clinical trials, and that emphasised this opportunity in the NHS and that unique data landscape, particularly in an out-of-hospital and community setting as well, and a £130 million package of support for the life sciences sector to enable that. And then finally, from a local perspective, the Levelling Up white paper for Greater Manchester and the Devolution Trailblazers, including our own Innovation Accelerator. How do we supercharge economic growth in the city region and bring inward investment, particularly to our underserved communities across Greater Manchester? So that's our national ambition. How does that then translate in terms of our local ambition around data analytics in GM? So last summer we published our analytics prospectus. That was a joint effort between NHS Greater Manchester and Health Innovation Manchester. And the analytics prospectus really is GM's vision for a fully connected data analytics ecosystem to not only meet but exceed what's required from an integrated care system nationally, and really bridge the gap between different aspects of a true learning health system through that development. And that's based around 4 core user personas And research and the role of research and innovation features as one of those core user personas. So it outlines our ambition around how the development of this infrastructure supports those 4 areas, including research. And you can see a number of those elements on the slide. So being able to access de-identified longitudinal patient data, being able to conduct retrospective research, but also generate real-world evidence and support things like clinical trial recruitment and AI development. Being able to have the assurance that your use of the data is protected through the 5 SAFEs model: safe people, safe settings, safe data, etc. Being able to link patient-generated information and patient-reported outcomes with the data in that longitudinal record to further augment your analysis. Being able to embed that research back into operational practice and really make a difference in terms of the front line, and being able to redeploy those models into that real world environment. So that's our local ambition, building on that national policy direction. So just to pause briefly for a second and thinking about the role of secure data environments, SDEs, as part of that picture. So what do we mean by a secure data environment for Greater Manchester? Well, there are a number of definitions you can see on the slide, one from HDI UK, the other from NHS Digital. And essentially, SDEs are these secure computing environments for remote access to data, particularly for researchers and innovators. I like to describe them, some people in the room will have heard me use this metaphor far too many times, but I describe SDEs sometimes as a virtual version of glove boxes that you get in a physical lab, where the radioactive material or sensitive material inside is health and care data, patient data, and the glove box itself is the secure data environment. You can still shove your hands in the box, you can still do important, crucial things and developments with the data, but it's in a safe, controlled, secure way within the boundaries of that secure data environment. And that's metaphor I use to describe this concept. Some of you will have previously heard about SDEs described as TREs, trusted research environments, data safe havens. The concept of SDEs is not a new idea, but what is new, what makes GM unique, is what's inside that glove box, the longitudinal record that Gareth described, across 3 million patients almost across Greater Manchester. So that longitudinal record will combine and link at person level, at patient level, data across multiple different care settings: primary care, secondary care, social care, mental health, etc. And because it's longitudinal, it means we can look backwards in time. For some patients, almost 15 years backwards in time. It's more complete GP data than CPRD, pulled from the GM Care record, as Gareth mentioned, over 400 GP practices across Greater Manchester, and more timely secondary care data than what we have from HES, the hospital episode statistics data nationally as well, using SUS. It's also augmented through bespoke local flows, so data sets that only exist here in Greater Manchester around dispensing and prescribing of medications, around 111 and 999 calls, and adult social care minimum data sets as well, part of that core longitudinal record. We can also, as I mentioned, enrich it with other things. So things like patient-reported outcome measures or data from remote monitoring solutions or applications we can link to that longitudinal record. And that's fundamentally built on this key central connection you can see on the slide, which is how data from frontline systems on the left-hand side flows onwards with some processing and cleaning to be used for operational purposes like system planning and population health management, and then onwards for research and evaluation after that, with only the appropriate and the right data being shared at every stage. Not every SDE operates in that way. Some of them have very separate, very discrete environments. But because of that connection that we have in Greater Manchester, it supports us to create that true learning health system. The insights that we generate on one side of that diagram, over on the right-hand side, can be more easily pushed back to the other side. What researchers discover in the secure data environment can directly translate into the front line and support those improvements in care, experience, and outcomes for people in Greater Manchester. So I mentioned at the beginning, today is a key milestone in a journey that we've been on for some time, and that journey started way back in 2017 through investment as part of devolution, investment in shared data infrastructure across Greater Manchester, particularly this analytics data science platform. Much of that was then significantly accelerated through the COVID pandemic and our response to the COVID pandemic, So between February 2020 and April 2020 that year, lots happened, the world changed completely, but we also moved from 50% of GPs sharing data to 99.5% of GPs sharing data in the space of essentially 8 weeks to support the COVID pandemic. And we used that to successfully deliver a number of research studies, which all supported our response to COVID-19 here in Greater Manchester. And then following that, we successfully secured some investment from NHS England nationally to develop the technology that we need for the secure data environment. Last summer, we took a monumental step forward by securing information governance across all of those 500 data controllers that I mentioned to continue sharing data beyond COVID and for other purposes. And Gareth already mentioned the key recent development in the approval of CAG to use that GM care record data post-COVID as well. Around the same time, we formally commenced the first phase of our SDE programme with the objective, which today's event means we've successfully delivered, of getting the SDE ready to launch and make available to people. Last September, we joined part of a wider regional collaboration with our colleagues across the Northwest to look at how we can federate our capabilities in Greater Manchester across a broader regional footprint. And that brings us to the launch event that we've got today. So over the coming weeks, we'll be finalising the selection of a number of initial driver projects and commencing support for those projects to use the SDE to deliver real research using real world data in Greater Manchester. And that includes a number from an academic perspective, our lighthouse studies that you'll hear a bit about today from a number of those. But in addition, a number of commercially focused projects working together with global industry partners to bridge that gap between health, academia and industry as well. And all of those projects are insightful, beneficial projects in their own right, but crucially, as Andy mentioned, they also help us to pressure test a secure data environment to find out what works well, what doesn't work so well, and get that real-time iterative user feedback from people, both in terms of their technology, but also the process as well, to make sure the user experience of accessing the SDE, engaging with the SDE, is as high quality as it possibly can be. And at the very latest, as you can see on the right-hand side, our aim is to open the secure data environment for wider applications for access by the end of this calendar year, and then scale usage of the SDE rapidly from that point. It will become the single front door to access Greater Manchester's longitudinal record, bringing together those fragmented pieces that I mentioned earlier, and we're already well on track to deliver on that ambition. So this is the final slide from me, and this describes some of the types of projects that the secure data environment will support. It isn't exhaustive by any means. There are other types of projects that might not be reflected there, but it highlights the broad priority classification areas that we want to focus on. Gareth's touched on a few of these already, but things like AI algorithm development, testing, training and validation of AI. Clinical trial activity. The SDE isn't a clinical trial system, but it can support key steps along that clinical trial journey. Feasibility, patient recruitment, efficacy through short and long-term follow-up using the SDE. Real-world studies, including health economics and cost-effectiveness studies that help in terms of health technology appraisals, etc. Translational research, so bridging that gap between discovery, development and deployment. Large-scale epidemiological studies, population health research, understanding inequalities in people's access to services. And then finally, health systems research, evaluating the way that the system itself operates and how that can be improved from a patient perspective too. And with that, I'd like to thank you all for listening. I'm going to hand back to Andy to introduce the next section, which is going to be a showcase of some fantastic examples of the kinds of projects we want to support using the SDE to benefit the people of Greater Manchester. Thank you, everybody.
Excellent. Thanks, Gareth, and thanks, Bradley. You know, I think they're being a little bit modest. This is a really pivotal advance, a pivotal step, the launch of the SDE and having the SDE available from now and later in this year. It's really important, not just for research, but actually for the health and wealth of our population, because it all interfaces. So, you know, it's a huge advance, and I just want to call out the huge amount of work that this is involved as well. Particularly call out Bradley, but it isn't just Bradley. There are an awful lot of people that have been working within the different work streams behind the scenes to get us to the stage where we are. And actually, we are in the leading pack if not the leader nationally in quite a lot of this. We heard we were the first to get CAG approval. It's just incidental, that was 2 days ago. I don't think it related to the timing of today. But the first to get CAG approval, the first to develop certain functionality, but we're definitely in that leading pack. Doesn't mean we can rest on our laurels. I think if we take our foot off the pedal, quite quickly other people will overtake us. So the pressure is still on to make sure we meet these deadlines, but more importantly, we meet the functionality which is there for our citizens and the reason that why we're doing this overall. So we do have a program board. The program board gets feeds of information and progress from all the different work streams. It is a quite wide group of individuals. So I chair it, but we have people from some of the trusts, we have researchers, a representation from the Combined Authority in Greater Manchester, comms, we've got Genomics England, we've got a whole variety of people who can give it good input on the overall direction of travel. But the work is done by the work streams. My job's easy. The work is really done by a lot of others. Now, on the final slide that Bradley was showing are some of the examples of areas where we think an SDE can really make a fundamental change, an exponential change in what we're able to do. And so as part of this, we've alluded to these lighthouse cases or these lighthouse studies. So they've been designed to pressure test those, what we're developing. Does it deliver what we're aiming to deliver? They've also are being chosen at the moment to really overlap with the different areas on that slide and also the different people that we want to be involved in the SDE in the end, to really make sure that what we've envisaged delivers the right things to the right people. I said that it's still being worked on, so we've got some front runners and I'm delighted that we've got some people here to talk about those. I understand there was a citizens panel yesterday reviewing some of the other potential lighthouse studies that will be promoted and pushed through. And just to highlight the bit about citizen there, Bradley mentioned that SDEs have gone through various names, including trusted research environment. Why do we not use that terminology anymore? Well, trust is something you earn, not something that you self-appoint. And so we need to develop that trust. And the citizen voice is really important in everything we're doing. And I'm pleased to say on the panel at the end of today, we have citizen representatives as well, but they are integrated throughout this whole program because there's no point in academics in ivory towers developing something which is not acceptable to the people that we want to impact through this program. So let's get on to some of those lighthouse studies. And I'd like to welcome up, I don't know if it's John or it's Rachel or it's a combination of the both, who are going to do the first talk, which is about the ADAPT project at the Christie. So thank you so much. Thanks, John.
So good morning, everybody. I'm John Radford. I'm Professor of Medical Oncology at the University of Manchester, and I'm lead for the Living With and Beyond Cancer theme of the NIHR Manchester Biomedical Research Centre. It's great to be here. Thank you very much for this opportunity. And on behalf of the ADAPT team, all of whom are highlighted on the first slide, I'd just like to give you a background to what the ADAPT programme is and how the SDE can facilitate its development and really start to show evidence for what we hope is benefit. So a little bit of background first. So the treatment of cancer over the last several decades has been a success story in terms of developing new and better treatments. And now more than 3 million people in England are living with and beyond a diagnosis of cancer. And this is estimated to rise to 3.5 million by 2025 and 4 million by 2030. These are Macmillan data. But what we sometimes forget in our interest in getting rid of the cancer in the first place is that some of those treatments have significant late consequences in terms of second cancers, in terms of cardiovascular risk, musculoskeletal and endocrine risk. And all of these work together, unfortunately, to undermine patients' survival and quality of life. And so if we're going to be really holistic in our approach to managing cancer, we need to focus, yes, on the cure, but also on the time after cure in terms of managing these risks so people can live fulfilling and long lives following cancer cure. And what we know is that traditional hospital follow-up of oncology patients is not currently fit for purpose. It is focused on disease recurrence in patients who are probably cured, and where the greatest emphasis should be on managing subsequent risk generated by treatment. And what we have is, across the world, internationally, guidelines about how these risks should be managed, but how does that actually influence practice? And so what we've developed is the ADAPT program, which is a link between guidelines and practical clinical steps on the ground by doctors and nurses and patients on an everyday basis. And what we've devised is a system whereby routine hospital follow-up ceases and patients and GPs are provided with individualized relevant information about the possible late consequences of treatment and how these should be best managed to optimize future health. Patients are not discharged, so they can gain immediate access to clinical nurse specialist advice if the need arises. And pleasingly, NHS commissioners have supported us since 2018. And what we do in practice is, as it were, introduce this to patients in years 2, 3, and 4 of follow-up. And at year 5, they have a bespoke consultation with a clinical nurse specialist. A long-term management plan is devised using a pre-written menu of relevant advice, and then an introductory letter, a treatment summary, and the long-term management plan is sent out in an identical format to the patient and to the GP. The patient remains on open follow-up with immediate access, no referral required if the need arises. And so this is just a little example of the sort of information that we provide in somebody who's had potentially heart-damaging treatment in terms of the risk of damage to heart muscle, to coronary arteries, to valves, to conducting tissue, and the sorts of things that they need to consider in terms of maintaining good health in collaboration with their primary care provider. So key points: don't smoke, have annual lipid, diabetes and blood pressure checks, eat a healthy diet, incorporate regular exercise. Not particularly surprising, but nevertheless needing to be stated so that people know what to do. And colleagues at the ARC, the Applied Research Collaboration, have kindly done some modelling on the impact of ADAPT on activity at the Christie. And as you can see, clinic attendance, blood tests, imaging have all reduced. So that pleases the local managers. And we've got some very good feedback from GPs and patients about how they respond to ADAPT and the sort of information that is provided. But there are wider research questions. It's not just about the Christie. What is the impact of this program more widely? And is it that simply ADAPT displaces activity from one bit of the healthcare system, the hospital, to another, primary care, in which case all we're doing is shifting the problem? Were the comorbidities that we identify initiated or exacerbated by the cancer treatment? Are the comorbidities better managed and associated with superior outcomes in adapted patients? Because that clearly is the acid test. And what are the consequences of cancer treatment on the patient in terms of health, their economic activity, their well-being, their quality of life? These are all the sorts of questions we'd love to address. And of course, the SDE will help us to address them. By interrogating GMCR and secondary use data, we'll be able to determine the number of primary care consults, the type of consults, the number of referrals for secondary care, diagnostic procedures, and so on and so on. And the ultimate objective is to determine whether ADAPT actually leads to an improvement in the life expectancy and quality of life of those individuals. So because of proper management of risk, there are fewer people arriving in emergency rooms with myocardial infarction, heart failure, stroke, advanced lung cancer when it could have been picked up by screening, advanced breast cancer when it could have been picked up by screening. All of those things is what we want to know about, because otherwise ADAPT is useless. And so this is what the health economists have drawn up as the sort of experimental plan. The adapted patients at the Christie are going to be compared with non-adapted patients from patients elsewhere in the GM system, and ideally in due course to those in adjacent non-GM areas when the federated model comes into place. And we'll do some comparisons, and those comparisons will be as shown on the slide. It's to compare change in healthcare use pre and post the ADAPT process, and to see if this has a fundamental change on the way in which patients are managed and the sort of outcomes that they can expect. And of course, none of this is of any value if it doesn't benefit citizens. And so what we also want, what this project will allow us to do is evaluate the impact of ADAPT on individualized care, because we want to activate the patients so that they're involved in risk management in collaboration with their GPs. We want to see how it improves, if it does, links between the patient, primary and secondary care. We want to see how it impacts on patients' involvement in their own care, in health outcomes, so the ER presentations, for example, if we could drive those down, that would be much better for everybody concerned, and of course, costs and efficiency. So that's really it in a nutshell. I'd just like to thank you very much indeed and offer congratulations to everybody who's been so involved in creating what I think is going to be a really important moment. In particular, Rachel Oakley, who's in the audience, the Senior Project Manager. Can I just sort of big up the whole role of project management? We academics can have some ideas. The project managers help us to keep us on track and to tell us to do things by a certain time and get everything done. But also everybody else, Jenny Spears, Bradley Queen, Graham Hale, Jonathan Massey, Will Whittaker and Tom Mason. Thank you very much.
Thank you very much. Excellent, and I agree about project managers fully. An excellent example of an initiative where there's a need, thinking about a way of addressing that need, but now we have the ability to provide the evidence that actually that initiative is doing what we meant it to do. And actually, if you think back over the last years and decades, there are examples of well-meaning initiatives which actually don't hit the spot, don't hit the targets. But now with the SDE, we can really prove the worth of this model. And so a very good lighthouse study, I believe. Great. So we're doing well for time. So thank you to the speakers so far. Do start thinking about questions that you want about the SDE overall for the panel discussion, including those at home or elsewhere who are tuning in. But can I invite up, I don't know whether it's Bill or Vidya or John, who are going to talk about the pharmacogenetic testing across Greater Manchester. Great, thanks very much.
Hi everybody, thank you so much for the invitation to speak today. I'm John McDermott, I'm a clinical geneticist and an academic at the University of Manchester. Our group are particularly interested in the concept of pharmacogenetics, how we can use genetics to improve the safety or effectiveness of medicines. And what we're going to speak about today is how we can leverage the SDE to understand the usefulness of that intervention in clinical practice on a population level. So genetic variation is common in the population. We all have around 3 to 4 million differences in our genetic code compared to the so-called reference genome. Some of that is what we typically deal with in clinical genetics. It can cause rare disease or cancer predisposition syndromes. Lots of it does very little as far as you're aware. But some changes can influence how we respond to commonly prescribed medicines. And our group are interested in how we can take knowledge of that genetic variation and apply it in practice to improve the care of patients in our population. And we've broken that down into a series of steps. So initially, you need to understand that genotype to phenotype relationship. How does a change in a gene influence how you respond to a commonly prescribed painkiller, for example? You might have a really robust genotype to phenotype relationship, but you need to ensure that there are technological solutions so that data is available to clinicians at the right time. That might be rapid testing strategies, or it might be embedding that data into patients' healthcare records. And so you might have a really good genotype to phenotype relationship, you might have a great solution, but you need to put that into practice. You need to show that that intervention isn't disrupting other aspects of healthcare. And by working along that translational pipeline, the idea is we can more easily get interventions into clinical practice. And embedded throughout that, we work with patients and the public to understand the acceptability of this approach. And critical is working with our health economic colleagues to understand the value of this intervention. And implementation, health economic evaluation, it's really important that we have good, robust outcomes. And for us, this is where the SDE is potentially incredibly powerful. So what we've been good at to date is this bit. That's kind of our bread and butter in genetics, understanding that genotype-phenotype relationship. Increasingly, we're starting to think about this right side of the translational pathway. Put very simply, when we give a medicine to someone, we want them to have an appropriate response and no adverse drug reaction. We know sometimes people have an adverse drug reaction, they have side effects. Other times they have a poor response to that medicine. But very simply, what we're trying to do is increase the number of people in that middle group and decrease the number of people in the groups on either side. And on an individual and population level, that has major health impacts. And so genetic variation is associated with poor response to medicine and adverse drug reactions. And we know there's lots of other factors as well. So it can be related to the chosen dosing strategy or other polypharmacy. But we know that many medicines need to be activated by enzymes in the body before they can have their desired effect. Common genetic changes, and 99% of us carry changes that can influence our response to medicines, can influence the activity of those enzymes so you can have reduced levels of your active metabolite. And the question is, how do we leverage knowledge of that to improve patient care? And in many centres, many countries around the world, this is being done as part of routine clinical practice. So in the Netherlands, in the US at many centres, you will have pharmacogenetic testing as you enter the hospital, that's put into medical records and used to choose the right medicines for you. But despite extensive evidence for multiple gene drug pairs in the UK, there remains a translational gap. There's 26 gene drug pairs with what we call explicit pharmacogenetic guidance, really clear guidance. In the UK, only 4 of those have reached practice. And so what we've been asked to do by NHS England over the last few years is develop a piece of work called the Progress Programme, which is thinking about how we can develop a pharmacogenetic testing service for the NHS in England. And so our approaches to pharmacogenetic testing, traditionally, it's been very reactive. The limited testing that we do, we're testing for single gene drug pairs. You see a patient in clinic, send the test off, weeks or months later, you might get a result. There's a limited applicability of that. It's not going to work for all types of medicines. So increasingly, what we're thinking about is preemptive pharmacogenetic testing. The idea that at a set point in someone's life, whether that be when they're diagnosed with a certain condition or at a certain point, age in their life, you would do a panel-based pharmacogenetic test. That's then integrated within their records and can be used throughout their life. And that's what we're addressing as part of the Progress Programme. And this approach, the value of it, was demonstrated in a recent article that was published in The Lancet, which showed that panel-based pharmacogenetic testing can reduce the rates of adverse drug events by 30%. So as a single intervention, that is a major, major outcome. So current practice, this is what we're doing. Patient presents, weeks or months later, we get the results. What we're trying to do as part of Progress is embed that data within a patient's healthcare records. Now, part of what we need to understand is how do we look at the impact of doing that? And traditionally, what we've done in pharmacogenetic testing has been around context-specific outcomes. So a few weeks ago, you may have seen in the news that NICE have made a provisional recommendation that patients who've had a stroke or a TIA should have CYP2C19 genotyping, which will dictate which antiplatelet medicine they have. And that's based on pieces of work that groups around the world have done, including our own, looking at outcomes like this. Patient has a stroke, you do testing for a single gene, and then your outcome is quite clear. Does the patient go on and have a further stroke? But for panel-based pharmacogenetic testing, we need to think about longitudinal outcomes because that context-specific outcome doesn't exist in quite the same way. A patient presents, we're not entirely clear what that exposure should be. Should it be age-based? Should it be based on certain diagnoses? And then we do panel-based pharmacogenetic testing. So it's not just around that single gene drug pair. It's related to potentially all of the medicines the patient is going to receive throughout their lives. But what that patient does as they move forward throughout their life, throughout their healthcare journey, will be incredibly different. The variation within that population is intense. And so you may have patients who don't go and receive any more medicines at all. You may have patients who are diagnosed with many more diseases who receive lots of medicines. And so modeling that and putting in that granularity is incredibly challenging. And what we need is real world data. And as part of the Progress programme over the next few years within Greater Manchester, we're going to have a cohort of patients who have had panel-based pharmacogenetic testing in the population, and extracting that data and understanding how that impacts their healthcare utilisation could be incredibly powerful. I'm going to pass over to Adair, who's going to speak a little bit about how we're going to hopefully do that. Adair.
Thank you, John. So just before I move on to why we think the SDE will be able to help us answer some of these questions, I just wanted to zoom out and talk a little about the bigger picture and how this works very strongly aligns with the wider ambitions of the NHS. So we'll all be aware of the NHS long-term plan and the Data Saves Lives policy paper, which both talk about accelerating the use of genomic biomarkers to make care more personalised and precise. And this is followed up by a joint report by the Royal Pharmaceutical Society and the Royal College of Physicians titled Personalised Prescribing, which talks in detail about the implementation of pharmacogenetics in the NHS and in routine clinical practice. It highlights how there is a tremendous potential to improve the safety of medicines and therefore improve patient care and outcomes, but also to save millions of pounds through increased medicine effectiveness. So there's a significant cost benefit to this work. And finally, from the NHS's green ambitions, you may be aware that over 25% of the carbon emissions in the NHS are related to medicines, particularly through supply chain and the pharmaceutical industry. So by making medicines more effective, by reducing patients having to take multiple medications that do not work for them, there is a significant opportunity to impact the potential sustainable impact of the NHS. And in Greater Manchester, as we've already heard a number of times today, we are uniquely positioned to work on this problem. So alongside some of the comments that have been made today already, and these are only some of the partners that we work with, of course, we work with lots more collaborators, but in particular, we have a thriving academic innovation ecosystem where we have deep expertise in genomic medicine. Over the recent years, under the supervision of Bill and John, indeed, we've developed a wide interdisciplinary collaborative team, which includes additional expertise beyond genomics, which allow us to work really closely on that implementation part of the translational pathway. Combined with having one of the largest genomic laboratory hubs in Europe, we are very, very uniquely positioned to be working on implementation of pharmacogenetics and other genomic technologies in routine clinical practice. So this includes expertise in digital and data, but also user-centered design, health economics, as we've talked about, implementation scientists. And now that we are moving forwards to implementation and impacting patient care on a daily basis, we can start to think about how can we use the data generated with that post-implementation to drive improvements and an incremental understanding of the impact of that intervention, and indeed create a learning health system for personalized medicines. So that's exactly what we're hoping to do. We're hoping to establish a linked data set of patients enrolled in the Progress trial to understand their longitudinal prescribing and clinical outcomes alongside admission statistics. And we think that we are uniquely positioned to be able to do that in GM. So our specific objectives are to assess the impact of pharmacogenetic testing in the Progress study cohort, comparing that to a matched control group. We will collaborate with the Manchester Centre of Health Economics to establish the cost-benefit analysis of this intervention. And finally, this is a piece of work that I'm really excited about, which is to work with our colleagues at the Centre of Health Informatics to develop risk prediction models to try to identify which particular patients or patient groups are most likely to benefit from preemptive pharmacogenetics. This is a question that's completely unanswered, and as John highlighted, we are unsure what that initial question mark exposure should be, and hopefully this will allow us to break the ground on that. This is something that I think is really, really unique and really at the bleeding edge of genomic medicine translation. So this is just a conceptual overview of some of the data that we're hoping to use within the GM SDE. And this is what we hope the anticipated outcomes would be. So we're hoping to provide novel insights into the impact of preemptive pharmacogenetics. And as I said, I think we're very well positioned to do that. And we want to hopefully use that to inform future policy and commissioning directions. Finally, we want to, of course, share. We are being pressure tested, as we've heard a couple of times today, and we're very happy to be in that position. But we hope to share our experience of using the SDE with future projects or future groups that want to work in this with this fantastic asset. So finally, our overall ambition is to bring personalised medicine to the clinical front line, making medicines more safe and effective and improving the health and well-being of citizens in Greater Manchester and beyond. We're very, very keen to receive your feedback, comments and criticisms. We're very, very open to collaboration. So please, if you've got any feedback, please get in touch with us. Our contact details are there, and you can find us on the university web pages as well. And thank you again very much for the opportunity for speaking and for selecting us as the Lighthouse Project. Thank you.
Excellent. Brilliant. Another excellent example there. And both of the Lighthouse projects so far have highlighted not just the SDE, but actually Greater Manchester. We've had the ARC mentioned, we've had Health Innovation Manchester mentioned. Later on, we've got Ian from the BRC mentioned. So not only have we got this pivotal SDE, but we've got the environment to make the real use of it, which I think is really important. I wouldn't work anywhere else in the UK because what we've got in Manchester, I think, is virtually unique. I really like both of those talks. I've got vested interests in both. In terms of the first one, I've had cancer treatment, and so I'm looking forward to the ADAPT programme. And in terms of the second one, part of my background is infectious diseases, I mentioned earlier on, and in HIV medicine, which is a major part of my work. Almost 15, 20 years ago, I think it might be the first routine pharmacogenomic testing was HLA-B5701 in a medicine called abacavir and abacavir hypersensitivity. And we've used that routinely for the last 15 odd years. But that was the example of, let's do one test because we're thinking about one drug. Isn't it exciting that we can have this vision or this horizon in the future? And the SDE, well, I don't think you could do it without an SDE, really. So an exciting project. But let's move on. So we now have, I think, Oliver, who's going to talk a little bit about ID liver. And thank you very much. Thank you.
So hi everyone, I'm Oliver and I'm a programme manager at the University of Manchester. I've had the real privilege of working on the ID Liver project over the last 3 years or so. So the ID Liver project is an Innovate UK funded consortia of NHS, university and industry partners. And it's a project which is designed to diagnose and detect liver disease much earlier in the community. So today I'll give you a brief overview of the project and explain how we plan to utilise the GM SDE to further improve liver disease pathways in GM and further afield as well. So to start with, well, what is the problem? Well, quite frankly, the current care pathway for liver disease just doesn't work. We're picking up people with liver disease far too late, and around 3/4 of people have a late diagnosis when often it isn't possible to reverse the damage to the liver. It's therefore unsurprising that liver disease is the third cause of premature death in the UK. There's also just too much of it. Approximately 1/3 of the GM adult population have risk factors for liver disease. This is simply too many people for the current system to identify, assess and move people to the appropriate care pathways in a timely fashion. In addition, it's just too expensive. Because the majority of people are picked up really late, they can have lengthy admissions to hospitals and expensive investigations. It should also be said that many of these people are of working age, and this of course has an impact on the economy as well. The way the system's set up also means that many people have to travel long distances to the hospital for their assessment. And unsurprisingly, this puts many people off from attending clinics. And finally, there are just too many unknowns. From a public perspective, there is poor awareness of liver disease, and there's often a stigma associated with it as well. Unknowns can also be said from a clinical perspective, as clinicians simply do not have the tools at the moment to know who's likely to progress to advanced disease and who is more likely to have no complications at all. So this is a well-used slide taken from the Lancet Commission report on liver disease, and it shows standardised UK mortality rates for some of the biggest killers in the UK since 1970. And what you can see is that the majority of chronic conditions have actually been reducing in mortality over the decades, And this is what we would expect with improving healthcare and improving technologies. Liver disease, however, isn't following this trend and has seen around a 400% increase over the last 40 years or so. So clearly, something needs to be done right now to address this major health challenge. So why Manchester? Why is Manchester the ideal place to address this? Well, in terms of the bad, which is not necessarily really a bad reason, but GM in the northwest of England have some of the highest mortality rates for liver disease nationally. This might sound bad, but actually the rest of the country is quickly catching up. And over the next decade or so, we're going to see the rest of that map turning a darker shade of purple. But right now, we've got the disease population already established for us to be able to begin to address this issue. There are also really good reasons that ID Liver is based in Manchester. Firstly, we've got a single hospital trust, which allows the region to be connected rather than working across multiple healthcare systems. We also have a devolved health and social care budget, so have a single budget that can be used across the entire region. Manchester's also a really multi-ethnic community, which means that what we find here can be translated to a much wider range of the population. And finally, we have an integrated primary and secondary care system. So what are we actually doing to address this issue? Well, we took the approach that in order to have meaningful change that works for individuals, we needed to establish a multi-sector partnership that includes NHS trusts, universities and industrial partners, both large and small. So that's exactly what we did. And ID Liver commenced in 2020 and is integrating data science approaches with multimodal diagnostics to detect people earlier and work out who is likely to progress to advanced disease. So we received around 2.5 million from Innovate UK through their second wave of the Life Sciences and Industrial Strategy Challenge Fund, and another 2 million matched in kind funding from our global industrial partners, Roche Diagnostics and GE Healthcare. And more recently, we've also received funding as part of the GM Advanced Diagnostics Accelerator, which is led by Health Innovation Manchester and funded by Innovate UK. So this slide is really just to very quickly highlight the consortium as a whole and all the different parts that were assembled in order to redesign the current liver care pathway. So firstly, we set up community liver assessment clinics and then integrated data and various diagnostics from a range of different sources, including things like novel imaging techniques. We're also carrying out biomarker analysis at the university and integrating this to detect liver disease much earlier. We're developing a risk prediction platform alongside our AI partner called Jiva and mapping a route to NHS adoption and commercialisation with the help of Health Innovation Manchester and TrustTech, among others. Finally, everything we do is designed alongside our public contributors, which include people with risk factors for liver disease. And at the moment, we have over 80 people that are part of our PPI network for ID Liver. And this is led by an organisation called Vocal, which is based out of the Trust. This engagement allows us to ensure that the innovation isn't something that's been designed in isolation of the people it will serve, but very much in partnership with them. So, how are people assessed then? We set up liver assessment clinics across Manchester, and we purposely set these up so that they are location agnostic. So whether these are set up in acute hospitals, community hospitals, primary care practices, or indeed mobile clinics, the initial assessment is always exactly the same. And we worked with an organisation called Northwest eHealth to identify at-risk patients through the GP records and invite them for an assessment in their locality. And a massive aspect of our success in establishing these clinics has been the result of using an NIHR research van, and this has been in partnership with the Trust. And this allows us to set up clinics rapidly and travel to where patients are in the community. We've set up clinics in places like community centres and football grounds, and you can see a picture here where we parked outside Old Trafford for a week, and that was a really great experience. And you can also see a quote from one of the patients on the van when we attended Old Trafford. And it's unsurprising that every single patient that we surveyed who were on the van said that they'd rather have this approach than travelling to secondary care. So given the work we've already done for ID Liver, how will the SDE add benefit? Well, access to linked primary and secondary care datasets will allow our population health analytics partner called Solace to generate heat maps of liver disease and provide a topography of localities at risk of chronic liver disease across Greater Manchester. This importantly will inform where we locate clinics in the future, where they're most needed in the community. And you can see on this slide an example of a liver disease heat map that was made by Solace for a previous project based in London. We'll also be able to describe the scope and nature of multimorbidity across GM and provide insight into the relationship between comorbidities and chronic liver disease. And finally, the Centre for Health Economics at the University of Manchester will also access the same data sets to inform resource use and costs of the diagnosis and management of liver disease. So to summarise, through ID Liver, we've built an end-to-end programme that builds on novel biomarker research and is able to translate actual benefits to the GM population and beyond. It's focusing on a huge under-recognised health need, and we're able to begin to address this through our multi-sector consortium and expertise across novel data science and fibrosis research. Importantly, liver disease is part of the constellation of multimorbidity. It doesn't happen in isolation. People with liver disease can have a range of conditions such as diabetes or risk of cardiovascular disease. And this is really an opportunity for us all to shape the integrated care systems and community diagnostic centres for a whole array of different health needs. So finally, access to this GM SDE is a fantastic opportunity for us to target interventions in areas with highest disease burden and gain further insights into the needs of the GM population and ultimately benefiting the public. Thank you.
Excellent. Another very good presentation and a very good project. And also this resonates with me, not because I think I've got advanced liver fibrosis, as far as I know I don't, but in my background, we've done a lot of work with hepatitis C, which was a major determinant of liver fibrosis in our population. Now treatable, now curable, but when I first started, it wasn't particularly curable and treatable. So I've been involved in the liver disease bit for a while, and also involved in getting the funding for that research van, which is another really important asset, I think, for Greater Manchester, with or without the SDE there. I don't think I've got lupus though either, Ian, so let's hopefully it won't resonate. That one won't personally resonate. I hasten to add, you know, I haven't chosen these lighthouse cases about things that resonate with me. They are chosen for those reasons we alluded to earlier on, that they are good examples of covering the areas we think are going to be most relevant for the use of an SDE, but also being able to pressure test. And we didn't specifically call it out, but I think an important point here is it's a learning process here. We're launching today, but it isn't fixed. This isn't the SDE which is going forwards. This is the launch. And so we are going to learn things from these projects, future projects, and we need input from you lot about things that worked and things that didn't work, or really good suggestions about if this could be tweaked or presented in a different way or provided in a different format. It would be so much more useful. We're doing this not to create an SDE, we're doing it to make a difference to research, to the health and the wealth of our citizens. And so your input will be really important in that. Anyway, we're doing well for time still, which is good. So can I invite up Ian, who is going to give the next Lighthouse study. So thank you very much, Ian.
Okay, well, good morning, everybody, and thank you very much for the invite to speak today. My brief was to talk a little bit about the project that we're thinking about for the Lighthouse, but then by way of background, also to introduce the Biomedical Research Centre and how this fits into our strategic plan and how we'll be sort of hoping to drive this whole forward. So I'm going to talk about the Biomedical Research Centre first of all. So as you know, I'm director of the BRC, and the BRC was awarded £59 million in December for a 5-year programme of work, basically with the aim of driving personalised health and care for all, which is our top-line mission. Now, as a BRC, this time we've expanded and we're now across 6 partner trusts along with the University of Manchester. So that's MFT, which is our host trust, as well as the NCA, the Christie, Greater Manchester Mental Health, but then also reaching out towards East Lancashire and to Blackpool as well. And the vision is really to try and bring personalised health and care for all to those rural, urban and coastal communities. And we've talked a lot about connectivity earlier, and we're embedded within a very connected system. And I think that was probably part of the reason for our success. So Manchester already has a very well integrated, functional crosstalk between its other NIHR infrastructure, as you've heard today. We reach through into Manchester Academic Health Science Centre, strong connections with Health Innovation Manchester. And that means that we can serve the NHS across the northwest, so in the GM footprint, but as well as into Lancashire and South Cumbria. And so for those of you who don't know, a Biomedical Research Centre fits at that early translational step. So if you think about the discoveries within, we've heard about discover, develop, deploy earlier today. So discoveries within the university, within the basic science infrastructure, that first translational step to prove the concept that this might work at a larger level. And that's then taken through into, with the CRN, with the ARC, etc., into things that will address the Greater Manchester healthcare needs. And we're part of that push and pull. So there's good ideas coming through from the university, from our discovery scientists, but there's also that pull of healthcare need. And a number of the projects you've heard already today are already part of that pull, identifying what the next needs are and pulling those through. So part of our vision is to embed early translational research further into our communities. And I think an SDE and the GM Care Record helps us to embed ourselves better into the community, to build a national powerhouse for innovation by pulling our discovery together with our other partners and building that strong research culture. And to understand that, you need strong foundations in the community. And then to accelerate at scale the impact of our research. And you probably know this metric that people talk about. It takes 17 years from you have an idea to it gets deployed. In Manchester, we get very, very good data, or very good examples of things that have come through in a much, much quicker, accelerated fashion. And we want to recapitulate that. Think about the PALO study. Think about some of the other studies that you know about in Manchester that have gone through in 5, 6, 7 years. So we can do that, but we need to be connected in order to do that. And that means that the system almost needs to be waiting for what it is that we're doing. And so that's about communication, and that's about integrating it into the system. And we address 3 major grand challenges. There's the basic understanding basic mechanisms of disease, a big focus on prevention, early detection, and again, you've heard some examples here this morning, and then thinking about person-centered therapies, interventions, and care pathways. And again, some of these early examples are in that ballpark as well. So not only were we able to increase our footprint of the BRC this time across geography, but we've also been able to expand the number of themes and the number of areas that we're working in. And then to try and drive integration within the BRC, so we don't just develop 13 themes or 13 silos of working, we've pulled our themes into clusters. And those are sort of the areas that we've got real strength and depth of research in Manchester. So that includes cancer, and you heard about the Living With and Beyond cancer theme, which is our new cancer theme for this time, but that integrates well with the other cancer themes. We get very, very strong, big strengths across Manchester in inflammation research. So whether that's rheumatology, where I am, whether it's respiratory medicine, whether that's dermatology and cardiovascular disease, because you know that heart disease is basically an inflammatory disease. And so therefore chronic inflammation underpins a lot of these conditions. We have at the bottom here a whole theme, or a whole cluster around disease complexity and multimorbidity. Multimorbidity is kind of the word of the moment, but actually when you think about it, diseases are complex not just because of multimorbidity, i.e. you've got a condition and you've got several other conditions that have occurred in a non-random fashion. So there's a common mechanism through all of that. But within a disease, there's complexity as well. So within rheumatoid arthritis, there are complex interactions, which means that there are subsets within that disease. So disease complexity, when we think about new therapeutics and new diagnostics, is driving that forward. And then we have a series of themes around high burden, under-researched conditions. So that's mental health, that's genomics and rare conditions, and hearing health as well. So these are major burdens in our community, but often not getting the funding that they deserve. Now, one of the things we have is the whole vision of personalised health and care for all. And in order to do that, you need to understand the population structure in which you're working. So we very deliberately set up what we call an inclusive research oversight board, and Arpana is co-chairing that. And this is to try and drive the principles of inclusive research into the BRC. So what you need there is your researchers working alongside the public and patient involvement, but also methodologists who understand how to find populations of excess morbidity, etc. And that was a beautiful heat map that Oliver showed. That's the kind of thing you need to understand where the disease is and where you take your research to the patients and populations. And then also matching that with civic priorities. So we've got ICS representation on the IROB as well to try and say these are the things that we're prioritizing as well. So just what inspired me to think about this and what inspired the BRC to sort of think about part of our strategy, and we've got a digital strategy within our core. We knew about what was happening with the GM Care record through the COVID pandemic and the number of ways in which the GM Care record was already being deployed to think about addressing major questions during COVID. And so within our written core digital strategy for the BRC, some of the unique selling points of the GMCR and the SDE were already there. And I think some of these examples include that idea of full population coverage, including underserved groups, linking to cohort, the ability to link cohort data from secondary care into the SDE, link other data modalities such as imaging, pathology, omics, wearables, etc., and then a platform to run prospective studies and interventional studies at a community-based level. So I'm a rheumatologist, and one of my major areas of interest is systemic lupus erythematosus. Now, some of you may not even have heard of it. It was even spelt wrong on the introductory slide. It was erythema. The ptosis is gone. So SLE is a classic multi-system autoimmune disease. So your immune system turns in on itself and it drives inflammation. And it frequently presents with things like rashes, often in a butterfly distribution on the face. People get arthritis, you can get pleurisy, but you can also get cardiac disease, you can get renal disease, you can get central nervous system involvement, etc. So it's a truly multi-system disease. It's got a huge female to male preponderance, 9 times more common in women than men. The peak age of onset is within the childbearing years, and that's really highly relevant when we think about some of the outcomes that we see and we think about pregnancy, morbidity, etc. It occurs in about 100 in 100,000 of the population, so it's uncommon, but it's not excessively rare. So it's probably about 3,500 people across GM with lupus. There's a very steep ethnic gradient. So we've actually done work in Manchester. We found that kidney disease in lupus is 5 times more common in people of an Indo-Asian background and 10 times more common in people of black backgrounds. And that's severe. That's the more severe end of the spectrum. But we also know that social determinants of health also affect outcomes in lupus. So colleagues in the States have done work where they've looked at things like people's experience of racism. So people's actual experience of racism or vicarious racism, they're living in communities where they know that there's racial prejudice, that actually can also drive adverse outcomes in lupus. So there's a really complex thing going on here. It's also multimorbidity central. So if you've got lupus, these are some of the conditions that you're more at risk of compared to people in the general population. So that includes many cardiovascular endpoints. If you're 35 and you've got lupus, you're 50 times more likely to have a heart attack this year than a woman of 35 in the general population, okay? Much stronger than most other conditions. Hypertension, chronic kidney disease, miscarriages, preeclampsia, stillbirth, certain types of cancer, infections. So Andy is right in the middle of lupus as well. So infections, one of the commonest causes of death in lupus is infection, and one of the commonest causes of hospital admissions is infections, and that tends to be encapsulated organisms like pneumococcus, etc., viral illnesses, herpes zoster, etc., and opportunistic infections. And of course, some of these are amenable to interventions, vaccinations, etc. So we've done a lot of work in cohort studies, mainly based in hospitals and mainly based in secondary and tertiary care centres, where we found that a lot of the determinants of adverse outcomes, some of them are fixed, like your age, your race, your ethnicity, your gender, but then also social determinants of health. But we also know one of the mainstays of treatment is immunosuppression, and one of the drugs we use are glucocorticoids. And glucocorticoids are the kind of drug that many of our patients can't live with and can't live without. They drive a lot of the comorbidities in these patients. And then inflammation, the chronic inflammatory state itself, but also these patients are more procoagulant, they're more likely to clot, partly because of inflammation, partly because of certain autoantibodies. So when we're thinking about moving forward lupus research in Greater Manchester, there's a number of the things that the GMCR SDE provide that are beneficial when we are opportunities for us. So full population coverage. There are certain things within primary care that happen to our patients that we don't record well in secondary care. So their vaccines, their cancer screening, even prescribing of routine drugs like corticosteroids, antimalarials, etc., but also their adherence to that, and we know very little about that. We have very little social deprivation data. Getting granularity on that will be helpful. And then also people who disappear out of the secondary care service and continue to be followed up only in primary care, we lose those in most of our cohort studies. Linking to cohort data, and we've already got a number of cohorts established. So a biologics register, we've got an early SLE cohort that we're following, and we do a lot of work on lupus and pregnancy. Other data modalities, so a lot of our patients have renal disease, and linking the biopsy data and the sort of the imaging data, etc., from hospital into an SDE would be great. Similarly with some of the work that we're doing on neuropsychiatric disease. And then thinking about prospective studies, looking at long-term outcomes, but then looking at interventions at a community-based level. So whether that's quality improvement, improving vaccine status, cardiovascular risk management, etc., that's the kind of thing that we could assess and track using this system. So just to summarize, for Manchester BRC, I think this is a huge opportunity, and I think many people within the BRC will be wanting to access the SDE. It gives a step change in delivering translational and early phase research with a focus on health inequity and inclusivity. So you can see across those many themes, there's going to be lots of ideas generated, and hopefully we can support people to do that. I think the GMCR and the SDE provides population-wide coverage, so that allows us to have a deeper understanding of people in place, drive novel insights on the interface of biology, behaviour and health, and the example I've given you about lupus is a good example of that, and then to support novel interventions within the GM population so we can improve health outcomes for all our citizens. So thank you very much.
Another excellent talk, and there was infection in there, so I do feel it resonates with me. Thank you for that. And I particularly like your penultimate slide to show really the breadth and the depth of knowledge and potential health gains that can come from the SDE being placed into just a disease, into SLE. SDE, SLE, we can get confused here, can't we? But it just shows the potential of what we're embarking upon now. So that was an excellent talk, and I'd really like to thank all the speakers for some excellent case examples. lighthouse studies. There are other lighthouse studies which cover some of the other areas, but we can't have them all here, and some of them are still being worked out, at the final stages of being worked out. But I'd like to thank the speakers for excellent presentations, but also for keeping to time, which means we can get to the panel discussion. So can I get the panel to come up and please sit here? And those that haven't already presented, we'll get them to introduce themselves, but when they're up here. So all of you come up here. I've got a few questions that I want to start off with, but I'm very keen that this is your session. So those of you online, please submit your questions, and I can't promise we can get through all of them, but we'll get through the ones that we can do. And similarly, audience in the room, it would be excellent if you can think of any burning questions that you've got. So there is a microphone somewhere. Do you want to, you've introduced yourself already, Bradley, so do you want to pass the microphone down, and then Niels can introduce himself and we can just go down the list. So Niels.
Yeah, thanks, Andy. So hello, everyone. I hope you can hear me okay. So my name is Niels Peek. I'm Professor of Health Informatics at the University of Manchester. I also lead the Christabel Pankhurst Institute for Health Technology Research and Innovation. I'm involved in the SDE delivery group that Bradley mentioned earlier on. So I'm connecting the work basically to the academic community in the university.
Brilliant. Nikki?
Hi everyone, so I'm Nikki Timmis. I'm the Public and Patient Involvement Engagement Manager here at Health Innovation Manchester, and I'm supporting the SDE team to include the public in the development of the SDE here in Greater Manchester.
Hugely important. Manoj?
Morning everyone, so I'm Manoj Mistry, a family carer from Greater Manchester. I currently look after my eldest sister who's 75, and she has a range of physical and mental health conditions, and I'm a public contributor at Health Innovation Manchester. Welcome
and thank you so much. Jenny.
Hi everyone, I'm Jenny Spears. I'm Head of Information Governance at Health Innovation Manchester. I also chair the Greater Manchester Information Governance Group, and I've been leading on some of the work. We mentioned the CAG application before, so I've been working with NHSGM and with the University of Manchester on getting us through that approval.
And finally, Matt, who's really important on the programme board as well. So Matt.
Oh, thank you. You built me up there. I'm Matt Hennessy. I'm the Chief Intelligence and Analytics Officer for NHS Greater Manchester.
Brilliant. If we can pass the microphone all the way back to Bradley, because I'll start off. As I say, please start thinking about your questions, submitting questions. But Bradley, I suppose almost a kind of summary bullet point, your thoughts type of question. So we've spoken about the SDE being pivotal, but in your view, why is it a priority for Greater Manchester? And what difference does it and will it make to our population, which is ultimately what we're here for?
Absolutely. Thank you so much, Andy. I like the pass the parcel with the microphone back down the line. We're working really well together already. And I think it was great to see the presentations from those 4 lighthouse studies that we've had already this morning, because I think for me, sometimes we can think about the development around the secure data environment, the GM care record, etc., very much as technology programs, as digital programs. But actually, it's not just about the technology, it's not just about digital, it's about the great work that having those capabilities and that infrastructure enables in terms of these research projects, but ultimately driving new innovation into Greater Manchester. How do we improve outcomes, create benefits for the people of Greater Manchester? And to do that, you need the right tools, you need the right capabilities. We've seen from each of the studies this morning the absolutely central role of data and access to appropriate data, linked longitudinal data, to provide those tools to deliver that great kind of work along every single stage of that development pipeline. So Ian spoke about the discovery stage through the BRC into development, how we get things ready for real world adoption, and then all the way through to deployment at scale. There's a role for the SDE throughout that entire pipeline. I think it's also about that real local focus in Greater Manchester. So I spoke in my presentation about some of the challenges that national initiatives in this space have had historically. How do we build solutions, technology solutions like the SDE, that absolutely have public trust and engagement with citizens really at the core and the centre of that programme? And it's great to see Nikki, Manoj, other public members in the audience today who support that to make sure all the work that we do brings that trust and that trustworthy journey along with us and alongside us. I think for me, an element that we've touched on through some of the presentations, but a point I'd really want to emphasise is that historically, I think it's fair to say, research, not just in Greater Manchester, but nationally, hasn't always represented the populations that are going to be impacted by these interventions, these solutions. We've not always seen the kind of diversity in research cohorts that we'd like to be really representative of our local populations. And so I do think there is a unique opportunity through the GM Care record, through this longitudinal record, that has input from all of our citizens, all our patients across Greater Manchester, for the SDE to support in a small way and in other ways in a big way, how we address health inequalities across Greater Manchester too. So for me, I think that's why it's such an important programme, such a pivotal programme to all the work that we do in Greater Manchester.
Brilliant. Well, we might pick up some of the things that you mentioned, particularly when we talk to Nikki and Manoj. But let's pass it one down. Let's go in order here. So, I mean, one of the things that's really important in research and in innovation and in new pathways, etc., is not to do things in isolation. So the SDE is part of a much bigger thing, but also to learn from things that have been tried before. The question for you, Niels, is as a researcher, are there examples you can highlight and that you're aware of about other data sharing initiatives that have worked well? And in what way have they worked well? What can we learn? But equally, are you aware of initiatives, without giving too much away perhaps, that haven't worked well? And what are the lessons we should take from that? So over to you.
Yeah, thanks, Andy. And yeah, I think it's fair to say that, you know, there's a lot that we know about this. So it's a topic that's been researched really, really well across the country, across the globe, essentially, but also here in Manchester. We've, for instance, organized a number of citizens' juries in the past where we asked people, so, you know, do you believe it's reasonable that we reuse your NHS data for other purposes, including research? What would be the conditions under which you believe that's not reasonable? What are the conditions that you believe is reasonable? So we really know a lot about this. The challenge, I think, is to actually do those things. So it's a little bit similar as the things that John explained for the pharmacogenetics project. We know a lot about relationships between genes and drugs. Now we have to actually do it. It's not very dissimilar here. So in terms of examples, as you say, there are very strong examples of how to do it and very strong examples of how not to do it. To start with the first group, there's one, I think, which is essentially a bit of a precursor to what we're doing here, which is a soft integrated record, which goes back about 15 years. And I think is a very good example of how to do it because it's been extremely successful. And what was key for the soft integrated record, I think, was clinical leadership. So there were a small group of GPs who stepped up and said, we need to do this. And they convinced the rest of the community, the clinical community in Salford, that it was a good thing to do, that it was safe to do, and it would provide benefits to both the clinical community and the patient community in Salford. And it did. There's other good examples. I think the SIL data bank in Wales has been around for about 10, 12 years now, and is also a very good example of something that's proven to be sustainable, trusted by all the stakeholders, and very successful. I think what's been important for them, at least that's what Ronan Lyons from the SIL data bank always tells me, is that they've promised never to work with the pharma industry, but also to never use the data for performance management. And that brought the GPs on board. There's other examples internationally. So, for instance, the ICES in Toronto, Ontario. I've visited them a couple of years back, and it's really impressive. So they've got a population coverage of about 23 million people. So it's a slightly different scale. They have been around for 20 years. What's been key to their success is that there's strong government involvement. So the Ontarian government finance is part of what they do, not everything, but there's a basis there. The second group, Bradley already mentioned some of those. So care.data is obviously, I think, the first example that comes to mind of a program that was not successful and basically did all the wrong things because it wasn't sufficiently transparent, I think, and it crossed some of the boundaries that people tend to indicate in all those research. So, for instance, there was a strong commercial element there, but it wasn't clear how exactly that would pan out, and that stirred up a lot of confusion and suspicion, I think, and eventually the program had to be stopped. Other examples, yeah, GDPR. GPDPR more recently. I think a bit of a similar story, very strongly led from above nationally. And again, those questions about what are the data really going to be used for, not being completely transparent, and then suspicion around what was going on.
Brilliant. Okay, well, thanks very much. I mean, some strong messages there, which may again come up in the further panel discussion. It's really important that we learn from others, but it's really important that what we're doing is for our population, but with our population as well, which is where Nikki and Manoj come in. So both of you, what do you think are the major concerns the public have on the use of data? And how can we best work with the public, with communities, with citizens, with groups in order to allay those fears? Because they've obviously derailed other projects for good reasons. They've been derailed because this wasn't a focus. So any thoughts on that?
Well, I thought it'd be interesting for the audience to know that we've been working closely with the Secure Data Environment Project team to recruit an advisory panel. And Manoj and also a gentleman, Russ, sat at the back there, is a member of our panel. We've got about 10 public contributors involved. The average age of our panel, I'm afraid, is about 50 plus. I include myself in that bracket. Sorry, Bradley, I know we're a bit older than you. So I think one of the key points to make there is that we're not going to limit ourselves. The advisory panel is absolutely wonderful. I mean, we've had 4 sessions so far. The first one was like an introductory sessions to bring the public contributors up to speed with what an SDE is and why we were creating one. And then the other 3 sessions has been discussion points about issues that panel members have raised or that the project team were interested to explore further with members. And we've had some really fascinating discussions, but we have only had 4 contacts so far, and we don't intend to limit ourselves to just engaging with the advisory panel, although it's bringing great value and will play a key role in making decisions at important points during this programme of work. So we are going to reach out further, and one of the examples from a panel member, Russ, only yesterday at our most recent meeting was the importance of including young people and finding out what their concerns might be around a secure data environment. But some of the things that have been raised so far, and if I just cover some of the key themes and then pass over to you, Manoj, is that okay with you? Because I'm sure I've missed things. So some of the things that have been covered so far is that the public are less concerned around the use of depersonalised data as opposed to identifiable data, obviously, which is used for the purposes of direct care. But they do want to make sure that any data that's used, whether it's anonymised or not, is safe and secure. And is only being used by and accessed by authorised persons and for the purposes that have been pre-agreed. One of the other things that's been raised is a lack of awareness, really, that the NHS is already, research is already taking place using data. So the SDE is actually going to strengthen the security around what's happening already, and I think the feeling has been a little bit of shock that that's been happening and that the public might not know that this is the case. So there's definitely a sense that the SDE is better late than never, shall we say, in strengthening what we've got now. I think also another thing that's been raised is around a lack of knowledge and awareness around the role of industry. In terms of working in partnership with the NHS, the public don't necessarily realise that already happens. And obviously there could be multiple concerns around industry having access to data, whether it's anonymised or not. And then moving forward, like I said, we do intend to do much more public involvement engagement. We're going to continue to work with the advisory panel throughout this programme of work, but we also intend to, do some wider involvement engagement. And this, in answer to your question, how can we work best with communities? Well, we need to ask them, and that's what we plan to do. And we will also use that as an opportunity to find out from different patient groups, different cohorts, different communities about how we can raise awareness, what should be the mechanisms for getting information out there. Just finally, before I hand over to you, Manoj, I just wanted to say that another key theme that you mentioned about the project that didn't work well, that our advisory panel have mentioned very clearly, is about the need for transparency, and also the need for transparency when something goes wrong. So that's something that the project team are really thinking carefully about as we move forward.
Great, excellent points. Manoj.
Nick has covered all the major points we've discussed in our 4 meetings to date. But as a patient and as a carer, being born and raised in Manchester, my issues in terms of health data, and this applies to any data, not just health data, is how it's sourced. Is it securely stored? Once that data is processed, it becomes information. Who holds that information? Is it securely stored again? And once that information becomes knowledge, i.e. in the public domain, again, who has access to it? Or is it private information? Again, is that securely stored? Is it used for the purposes intended? And what we touched upon yesterday is access by, say, third-party organisations. Are they UK-based, or are they a subsidiary of a much larger organisation who we have no control over what they're going to do with data? Say if it's an unethical organisation, for argument's sake, based in South Africa, what are they going to do with UK data? So who has control over access to that data? So we have to have effective due diligence procedures in place to ensure that health data, so my sister's data, and she's been a patient now for over 40 years because she's a range of physical and mental health illnesses. Who has access to my sister's data, and will it be used for the purposes intended? What guarantees do we have as residents of Greater Manchester that there's no misuse of, say, my sister's health data? These are just general points.
Brilliant. Excellent, excellent summary and picking out the important points there. So wonderful. And I didn't organise the seating here, but it flows quite naturally now to information governance, doesn't it? And so Jenny, I mean, what important lessons have you learned about Greater Manchester-wide information governance, including, you know, setting up the GMCR? And what does this mean for the SDE programme? So give us your slant on all of this.
Thank you. It's a perfect segue from Manoj. All of those points that you've just raised are exactly the points that I need to answer, you know, and make sure that we cover that from a Greater Manchester perspective. And we will be doing that. And we've done a lot already, a lot of work on that. What has been key from the very beginning is the transparency, again, that Nikki mentioned. So informing the public, involving the public, communication, engagement, you can't say those words enough. And what is very clear is what you might class as the custodians of the data already, so the GP practices, clinicians working in hospitals, mental health, you know, they see themselves as custodians of that data already. And when it's internalised within their own infrastructure, they're aware of the security elements around all of that. When you start integrating that data and moving it around, we need to make sure that we are explaining exactly where that data is, what's happening to that data. Like you said, is it in the UK? You know, exactly where it is. And I think a great example is Bradley's slide of the SDE that shows that almost, you know, that box that you wouldn't extract the data out in any identifiable form in order to do that. So you keep that security element very much internalised, you know, within that environment. But somehow we've got to explain all this and make it relevant and understandable to the public as well, which is why it's absolutely vital that we've got the citizen engagement panel, you know, that we've got, and the work that we do with them. So there is more work to do. on the secure data environment. We need to have a public presence, a web presence, but not just a web presence as well. What information are we putting in our patient contact points as well? We've got patients now that no longer need to go into the GP to see a poster that might be put up there. So what are the different ways that we need to think about making sure that we're getting that message across? And that is the work that we will be doing with communications and the patient engagement panel as well.
Brilliant, great. An important point is just having our eyes open about the areas to look at and try and address them. But the work's not done, as you say. There's plenty more still to do, so that's great. Matt, last but not least, I mean, so the question that I was going to ask you here is, we've been talking about data for research and innovation, but data is used in a whole variety of ways in healthcare and by the ICS. And how, in your view, can what we're talking about with research and innovation, how does that complement the ICS's use of data? And how can the two, NHS analysts and really researchers, work alongside one another, do you think, most effectively?
Thanks. The question's a really important one. It's why we set out on this journey, because I think if you look at other examples of what we've tried to do across the country, there's a separation between research and operations, and there's a data set or a data store that researchers access, find out some amazing things, write algorithms, write machine learning. There's all sorts that's happening in the research space. And then there's a job to try and lift and shift it so it can actually be used by commissioners, people who are deciding pathways, redesigning, optimizing pathways, deciding where to spend limited money in a complex system, or clinicians deciding what's the best course of treatment for a patient. And that's a sort of artificial separation that we really, from the start, sought to get away from. We want one data source and have these two applications sat on it, so that if we do find out, and I think the Lighthouses are brilliant examples of doing some research and then thinking, how do we get this in front of the people who make decisions so that they can make better decisions? And so that's the journey we've been on, and I think one of the key components of that journey is actually recognizing that I think the prize for a lot of people has been trying to put all the data in one place. When I started to reflect on what's the unique selling point of the Greater Manchester version of that, it's actually the wisdom and expertise of everybody in the room. That genuinely speaking, the world experts we've got here in their particular field, you can't be experts at everything. So we need to get everybody in the room. There's a lot of examples I can think of where take primary care. In primary care in Bury, to serve its community has to operate in a certain way. And that's a slightly different way that it might be operating in Trafford. There are people who understand those differences. They're probably not necessarily the researchers, because the researchers are experts in all of the fields, the topics, the methods, the analytics. So we need to be able to connect. It can't just be about the provision of data. It has to be about the provision of wisdom and insight from people operating in the front line, who can then work with academics and industry and say, well, you know, you're looking at that data, you know, they code it differently over here than they do over there. And I think that's where we get the genuine intelligence and the intelligence that's actionable. So I think we built a platform. We've got the community, including patient representation in that community. So I think using the wisdom of everybody, I think we could really drive forward and develop actionable intelligence.
Brilliant. I like wisdom and insight. I'll remember that as a nice little phrase there. Okay, I like being chair because I can ask the questions I want, but actually it's over to you lot to think about questions. Now, we've got some online and we do have a roving mic. Should we do one online first and then the roving mic will go to the back, if that's all right? So you've got that microphone, Peter.
Yeah.
Hi, good morning, everyone, and to the panel. So we've had about 80 odd people joining us online this morning, and those online, apologies if you've experienced any streaming issues. But had a number of questions, but I'll take the first one, which is around Bradley, actually, to you. You mentioned that there'll be further projects using the SDE be considered before the end of 2023. I just want to know, what is the application process? How are lighthouse studies decided? And around sort of dedicated comms policy around the SDE. So that's from David Rogg at Salford Royal.
Yeah, thank you, Peter. I think it's a great question, and well, I think one of my key takeaway messages from all of the discussion today has been this idea of a journey, and the journey that we've been on around the development of the SDE to get to this point. And it very much builds on what we've done previously around the analytics and data science infrastructure, what we've done previously around the GM care record, to now move into this space of access to the secure data environment. And so because of that, things like operational processes, application forms, governance, all the nuts and bolts that make this process work. We've got tried and tested ways of doing that we've used before for the GM care record. We've delivered nearly 20 successful studies using that information and that process. And so we can take those lessons and apply them to the SDE in terms of how we move through that. So we're focusing very much initially on these lighthouse studies combined together with some commercial and industry focused work, partly to deliver the benefits that we see from all the great projects that you've heard about this morning, but also to pressure test that process even more. It's a continued iterative journey of constant feedback from users. How do we build on what we've got today and improve that even more tomorrow? So we're focusing initially on these lighthouse studies and some of the driver projects with an industry focus, and we'll run those over the next few months with the ambition that by the end of this calendar year, we'll start to open up that application process. In the meantime, I would very much encourage anybody who's got feedback on what you've heard today, who might have great ideas about how you want to use the SDE, to come and speak to one of us, come and speak to myself, come and speak to Niels or the research operations team, because we're keen to start to populate that pipeline of studies and pipeline of activity that follow after the lighthouses. So we've got that real focus on delivering great work first across some of the projects you've heard today, but then we'll open up the gates thereafter to all of the other interested areas that we want to cover. But come and talk to us if you're interested.
Brilliant answer. Okay, we've got about 5 minutes still for questions. So I think there's a question at the back first.
Hi, Bradley. A question for you, mate. You're in Manchester and you're trying to sell the SDE. You've got to speak Mancunian. At the start, at the start, you talked about a CAG. If you go into Piccadilly Gardens and say, we've got a CAG for the SDE, what's a Mancunian going to say? Because I have no idea what a CAG is, and I've attended how many meetings with you?
Yeah, no, I think it's a great question, Russ. You're speaking my language there. So for anybody that doesn't know, I'm a very proud. Well, I was going to say Mancunian, but that's controversial. I'm from Salford, so just across the well, actually. And I do genuinely feel very passionately about the difference this programme makes to people here in Greater Manchester. I think what you've mentioned, Russ, really builds on Jenny's point. I'd be interested in Jenny and Nikki and manager's view on this as well. How do we make all of this accessible to people? We've talked about CAG, Confidentiality Advisory Group. What does that really mean on the front line? We talk about research projects today, the stuff that John and Rachel and the team and other lighthouses have talked about, really help to articulate what difference this will make to people on the front line. And we've got to talk the talk and make it accessible and relevant to people as well. I don't fancy standing up in Piccadilly Gardens anytime soon talking about the CAG, but how do we use the right terminology to make sure that people recognise the benefit and the real importance of the work that we're doing together?
Okay. Any one-line comments from you, Nikki, and you, Manoj, and then we'll move on. So just really quick.
I was just going to say, because it's such a complicated area to explain, the comms and raising awareness about this is going to be one of the greatest challenges. And I think the only way we can do it effectively is by working with communities so that they can co-design how we do that.
Brilliant. Manoj, one-liner.
I was going to take it one step back. Everything Jenny said was perfectly valid. But if we stop 20 people randomly in Oxford Road outside this great university, 10 women, 10 men, and we asked them what health data meant to them, how many will have an accurate description of what health data is? We're going to get 20 different answers.
Absolutely.
So we need to take that step back in defining what health data is in the first place.
Very good point. Excellent. So, Peter, we've got people in the audience. I don't know about online questions because you're fielding those. So we've got an audience question. So thank you.
Thank you. Anshuman Chaturvedi, a pathologist at Christie Hospital. I'm also the pathology lead for the Experimental Cancer Medicine Center Phase 1 trials. My question was the two parts, but I'll stick to one in paucity of time. So there are national trials that are also being conducted, which GM is leading on. And obviously the SDE is being created within GM, but there is the ambition to integrate and interact with other SDEs as well. What are the plans around that?
Okay, good question. I mean, there's a federation in the Northwest, but a very quick answer from whoever's best placed. Oh, well, it's being part. People didn't want that one. Okay, Matt, a quick answer.
I am it then. Okay. Yes, the idea is that we've got to walk before we can run. So building confidence, Andy was absolutely right. It's earned. So that's why we want to focus on getting the GM SDE as a part of business as usual, a trusted part of business as usual, but then have the ability to federate with other systems. And I think that's how we run. We walk with our GM level SDE, and then actually there isn't too much heavy lifting to do to integrate with other systems because we have the key components we need in Greater Manchester.
Brilliant. And I think some of the reasons other projects may have stumbled or fallen is because they perhaps tried to be too big and run before they could walk. So I can see the logic behind that. Peter.
I've just conscious of time, really, and we've got a number of questions online. But what I'll do, I'll respond to them directly to those people who've posed them online, and then maybe if we could, if you've got specific questions from the audience, if they could grab people afterwards, if that's okay. But yeah, if that's okay, Andy.
Yeah, no, that's absolutely fine because we do have a hard stop, and so yes, we'll respond to the ones online. People in the audience here, catch people who are the panel here. Panel, stay there, but I'm going to pass over to Gareth, who's just going to sum up a little bit of his thoughts about the last couple of hours. But from my point of view, thank you very much, everybody, for all your input and enthusiasm. And this is the start of a journey, so I'm excited by it. Gareth.
Thanks, Andy. So I'll start with continue your thank you. So firstly, a huge thank you to all the presenters today. And also a huge thank you to the teams who've done an enormous amount of work to get us where we are today. I'd also like to specifically call out the citizen panel. So Manoj, Nikki, thanks for your help, and Russ, likewise, thank you for all your time. And it's really important that we see that the ambitions of the SD are rooted in what it is that we're trying to do for our citizens. I mean, some personal reflection for me. I said that I've been here now 4 months, so about 120 days, and in that time I've absorbed an absolute blizzard of information. It's been really quite overwhelming, and I think if there's one thing that's really cut through all that information, it's this, because we can see why we're building that digital infrastructure, the technology to cut through and get straight down to the impact on the front line with the citizens. So for me, this has been hugely inspiring and hugely invigorating in the context of an enormous amount of information coming at us. So I think I've got sort of 3, 4, 5 key points. What have we heard? We've heard that GM really is at the leading edge. As Andy said, this is massive for Greater Manchester and the 2.8 million people who live here. It's a significant development that really puts us at the leading edge of using technology and data to drive innovation. We've heard that the SDE is absolutely integral to our ambitions, both locally, nationally, and also with our relationships with others, such as the BRC, as Ian described. The SDE really must be connected to the citizen and staff expectations. It's essential that the SDE functions within tight guidelines, as we described. Trust must be earned and maintained, and it's important that we maintain transparency all the way through. Russ, great call out about being Mancunian. I think it's really easy, and I'm guilty of this as well. We can get lost in all the detail and the syntax. We've got to make this thing real and relevant to people who live in Greater Manchester and whom we serve. We've heard some fantastic use cases: cancer, pharmacogenetics, liver, lupus, and these all have addressed things with the basic mechanisms of disease, prevention, detection, and importantly, personalization of care. So all these themes ran through those 4 use cases. And finally, I think what all the use cases and all we've heard about today, it all drilled back down to that citizen focus of what are we trying to achieve? Why are we all here in this room today is to improve the experience and the life chances of the 2.8 million people who live within Greater Manchester, and to try and address some of the inequalities that we all know exist. So a huge thank you to everybody here today, a huge thank you to people who are not here but have contributed to this project, and a specific call out for all those people who've worked on the citizen panel to keep us where we need to be with this project. I really look forward to working with you all over the coming weeks and months. It would be great if we could do a subsequent event in the not too distant future, Peter. So I think we need to sort of pick up with that and think about how we continue to communicate out around what we're doing with the SDE and take that specific feedback. But thank you, appreciate your time today, and really look forward to working with you in the future.